Time flies like an arrow, fruit flies like a banana. It's already time for another Puscast, a review of the infectious disease literature. This one is covering the last 2 weeks of January in the year 2018. References are over at edgydoc.com, along with links to other aspects of my multimedia empire of apps, blogs, and podcasts. It's really quite amazing. I've written over 1,200 blog entries for Medscape. I'm about to hit my 1,000th gobbet of Puscast, and I've done a little over 270 of these Puscasts. And you know something? I get 0 CME credit. I figure I do like 450 hours a year, lowball figure, doing these things, and I get zip CME for it. I know, I asked the state, can I get CME? They said nope. I know, I complain a lot. But this year, I get to go to San Francisco to listen to old academics drone endlessly on things I pretty much already know, because that's how you get CME. Yay. So anyway, enough of the whinging. Let's get on to the literature, shall we?
Let's go surfing now. Everybody's learning how. Come on a safari with me. Come on a safari with me. Early in the morning we'll be starting out. Some honeys will be coming along. We're loading up our woody with our boards inside and heading out singing our song. Come on, baby, wait and see. Yes, I'm gonna take you surfing with me. Come on along, surf, baby, wait and see. Yeah, I'm gonna take you surfing with me. Let's go surfing now. Everybody's learning how. Come on a safari with me. Come on a safari.
That little copyright infringement is to remind me that being a beach boy, of course, is not a healthy lifestyle. Brian Wilson liked to have his bare feet in sand when he wrote his songs, and I have talked about sandboxes as a source of salmonella in the past. But most of the surfing areas are downstream from waste disposal plants, sewage treatment, for example. And the consequence of that is that surfers have a higher chance of antibiotic-resistant bacteria. These authors looked at stool specimens from 143 surfers in England. Did not know England had good surfing. And surfers had 3 times the rate of cefotaxime-resistant E. coli, probably from swallowing water while surfing. This, of course, is not the first time that the waters of the coasts have been found to contain antibiotic-resistant organisms. VRE and MRSA have been reported on California coasts, probably washed down in the effluent of sewage treatment plants. So if you're going to go surfing, keep your mouth closed, because there's E. coli on that surfing safari. If bum in this particular title, it was the Beach Bum Survey, was picked deliberately since bum is a British term for the buttocks and they looked at E. coli. I wonder if it was a deliberate double entendre. I hope so. Those Brits can be cheeky. I've emailed the lead author and I'll let you know. Well, let's leave the 60s and go on to some more modern stuff. Next up, some Nickelback, which reminds me... Just kidding. I sort of grew up in the beta-lactam era and have always been a fan of penicillins and cephalosporins over other antibiotics. And I think arguably they are still best of breed. One of the problems is penicillin allergy, which is bogus most of the time, leads people to give second-line agents. And recent studies have shown that there are poorer outcomes in patients who receive second-line therapy when they are, quote, allergic to penicillin. Now there's a study that shows that patients who get alternatives to penicillin because of an allergy have a 50% increased risk of a surgical site infection. Quote, the increased SSI risk was entirely mediated by the patient's receipt of an alternative perioperative antibiotic. And that's what happens when you get gentamicin, clindamycin, or vancomycin instead of cefazolin, or as my pharmacist pronounce it, cefazolin. Most of the time with pen allergies, I just take a careful history, and if it's not compatible with a type 1 reaction, then I just give it to them. To date, I haven't gotten into trouble with that particular approach, although other places do penicillin allergy testing prior. I've mentioned one of my few pieces of magical thinking. I always put an EpiPen in the room, and if you do that, it will never need to be used. But I suppose that would require the surgeon to take a careful and thoughtful history as to the antibiotic allergies. Yeah, that's going to happen. But I think the data has come out this year that part of antibiotic stewardship should include penicillin allergy testing. A review of zoster pneumonia out of France was fairly impressive in how bad this disease can be. 40% of normal people died versus 92% of immunocompromised who died. Half of the patients were ill enough to end up on a ventilator. Also, they frequently had both hepatitis or encephalitis. And at least in this retrospective series, giving steroids for the pneumonia was not only not beneficial, steroids increase risk of stay and was associated with an overall worse outcome. So while they've gone back and forth over the years on steroids with zoster pneumonia, this large study with only 10 patients who received steroids suggests that steroids isn't a benefit. But when it comes to steroids and infections like this, there are some things man was not meant to know. Long-time listeners know how I like to harp on the prothrombotic effects of infections and how after all sorts of infections, myocardial infarction, pulmonary embolism, and stroke rates go up. This New England Journal article looked at the rates of myocardial infarction after an acute respiratory infection, and the risk of an MI in the first 3 days after onset of symptoms goes way up if you have a respiratory tract infection. Especially for influenza, quote, the incidence ratio of an admission for acute myocardial infarction during the risk interval as compared with the control interval was 6.05, end of quote, whatever the hell an incidence ratio is. A similar effect, although less, was seen with RSV and less still with other respiratory viral infections. It's bad to get inflamed, and influenza is one of the worst when it comes to vascular complications. I don't know about this study. It was a study in the Journal of the American Geriatric Society that suggests that we underdiagnose flu in hospitalized older patients. And they pointed out that the elderly weren't getting tested for influenza. Certainly, if patients have an influenza-like syndrome, and that is, and I cannot emphasize this enough, a coughing illness. Influenza is a coughing illness. If you don't have a cough or upper respiratory tract symptoms early, you don't have influenza. It is virtually never a diarrheal, febrile, non-specific illness. So they complain in this that patients who are elderly and present with non-localizing fevers aren't getting flu tested. Now, I've gone looking, and maybe it exists, but I can't find it. As best I can tell, the sine qua non of influenza is a cough. If you don't have a cough, or again, early on, stuffy nose, runny eyes, before it marches down into your lungs, you don't have flu. Flu is a respiratory infection. People being admitted with fevers and undifferentiated fevers and febrile illnesses should not be getting flu tested. In this couple weeks alone, I've seen patients with endocarditis, scrotal cellulitis, and other infectious diseases with no respiratory symptoms whatsoever getting flu testing done, and it's negative. If there's an article that supports doing flu testing in people of any subpopulation with zero respiratory symptoms, I can't find it. But I'm sure my erudite listeners will soon send me an article to prove me wrong. So, FYI, a study shows that monoclonal antibody directed against rabies is equal to the usual immunoglobulin, which is derived from immunizing humans or horses. And in a trial where they looked at predominantly dog bites and prophylaxis, the two products were the same. Or perhaps I should say the monoclonal antibody was non-inferior. I know clinical trials need to be done, but boy, I wouldn't want to be in a alternative agent wing of a rabies trial. Still, it's a lot easier to make monoclonal antibodies in large amounts than it is to immunize horses and all the problems of other animal sera. So it's a good thing it worked. If it hadn't, I'd feel sorry for the bastards that went on to get rabies. How long is the HPV virus good for? Well, This trial, 12 years in now, in the Nordic countries, showed no breakthroughs with the quadrivalent vaccine. Humans get rhinovirus C, where it causes influenza-like respiratory symptoms and asthma exacerbations in children. However, in wild chimpanzees in Uganda, rhinovirus C caused a lethal outbreak. Usually we get fatal outbreaks from apes. Now we've returned the favor, much to the chagrin of the chimpanzees. They helped give us Ebola. We gave them rhinovirus C back in return. Fair exchange. Historically, the gastroenterologists in my system have taken care of hepatitis A, B, and C. So I know there are these therapies out there for hepatitis C that are quite effective. And I know I'll probably get tested on it when I get board recertified. But really, I don't care. This study in the New England Journal looked at some drugs I'm about to mispronounce. Glecapavir plus pentribsphere, I guess. Glecaprevir, PIBRENTASVIR. And they treated HCV genotypes 1 and 3 for 8 or 12 weeks and had great outcomes. Yay, who cares? I feel this sort of obligation to mention it, but again, the expanding known range of Borrelia miyamotoi, this is now found in northeastern China. This spirochete certainly is worldwide in its distribution. And now we can add China to the United States, Japan, Europe, and Russia as the distribution of Borrelia miyamotoi. Yet another tick-borne illness. Remembering that it causes a febrile illness, nonspecific, occasionally with a rash or an eschar or lymphadenopathy, but those three are distinctly unusual. So there are people with this post-Lyme syndrome of poor cognition and headaches and the like. This study evaluated the spinal fluid of these patients using a variety of immunoassays, as well as looking for CSF levels of the CXCL13, which is very sensitive and specific for neuro-Lyme. And they found these patients did not have evidence of Lyme disease, although interestingly, they did have some alterations in immunologic parameters that was identical to patients who had similar syndromes but no Lyme history, suggesting that, as I think is the case with things like post-Lyme disease and other maybe post-infectious disease states, that there's some final common pathway that perhaps leads to immunologic activation to give these poor people their symptoms. But it's more data to show that when you get treated for Lyme disease, Lyme is no more. It's a dead parrot. The French have noticed an increase in ocular syphilis cases at an ophthalmologic reference center in the years spanning 2012 through 2015, and I will just say I've seen a similar issue. I see a big chunk of syphilis in the last decade or so coming from our ophthalmology clinic. The most aggravating of which I've talked about over on my Medscape blog, are those who are positive for their FTA but negative for their RPR, yet have uveitis of some sort with no other explanation. And the question, of course, is whether or not this is syphilis in the eye. And there's not a clear-cut answer, but probably. As I've said many times before, both syphilis and TB remain the most aggravating diseases to try and diagnose. And as I've said before, my CSF VDRL is a false positive. Or am I oversharing? And a reminder that we are nothing but sentient transport media for resistant bacteria. There was a ceftriaxone-resistant Neisseria gonorrhea reported in Canada, and they think it came from Asia. Evidently a failure of Canadian border security, allowing a strain probably from Japan into Canada. And of course, from Canada, it will come to the United States. If we're going to build a wall, can't we build one that keeps out infectious diseases? I mean, watch out for them Canadians, don't you know? Some resistant organisms, a pan-resistant Acinetobacter, for example, are awful for an individual patient, but they don't present the epidemiologic risk that resistant organisms like gonorrhea or Staph aureus do. And I think it's going to be gonorrhea that's going to be the first common organism that is going to be untreatable. Yay! Let's all clap. Strep suis has been reported to cause meningitis and bacteremia, predominantly cases coming out of Southeast Asia. There have been a smattering of cases in the United States, and now there is a new strain in Madagascar that caused meningitis and sepsis. The patients were occupationally involved with pigs, and their strain of Strep suis had not been reported before. So beware of this little piggy. It will give you reason to cry, cry, cry all the way home. There's been some interesting studies I've talked about in the past on chronic inflammation increasing the risk of dementia. This study looked at cognitive outcomes after community-acquired pneumonia. It was a mere 58 patients, but the results are interesting, and I'll just read you the conclusion. Quote, a year after hospitalization for community-acquired pneumonia, moderate to severe impairment in multiple cognitive domains affected 1/3 of patients over 65 and 20% of younger patients, and another third of survivors had mild cognitive impairment. And that's pretty impressive. It's bad to get infected. A couple other things concerning community-acquired pneumonia. A meta-analysis on steroids in CAP showed patients got better a day faster, but the downside was they're more likely to be admitted and have hyperglycemia. I think on balance, the meta-analysis here would suggest don't give steroids. And you always wonder about an immunodeficiency or a predilection for having pneumonia. This study took blood samples from patients with pneumonia and checked their immunoglobulins and complement deficiencies and found, surprisingly to me, that, quote, low admission levels of any IgG or mannose-binding lectin were not associated with disease severity, short-term outcome, or long-term outcome. And it did not adversely affect the microbial etiology of their pneumonia. So it would appear that having small holes in your immune system doesn't make a difference when it comes to both if you get pneumonia and how you do with pneumonia. Probably a credit to the massive amount of redundancy that we have in the immune system. And I always ask about hot tubs, swimming pools, and saunas in my patients. There was an outbreak of Legionella in people who participated in the hotel aquatics facility. Although the CDC report does not mention whether it's swimming pools or hot tubs or saunas per se, I have certainly seen a smattering of Legionellas in my day that I've linked to hot tub use. I'm of the personal opinion that if you keep your blood alcohol level high enough while in the hot tub, you can't get Legionella. So that's my approach to my hot tub. I've seen one case of hemolytic uremic syndrome in a patient with pneumococcal pneumonia. That was probably 15 years ago. Now there's an article in the Journal of Infectious Diseases that describes the pathophysiology of HUS in pneumococcus. It'll go in one ear and out the other for me, but, quote, pneumococci efficiently bound human plasminogen via the bacterial surface proteins TUF and PSPC. When activated to plasmin at the bacterial surface, the active protease degraded fibrinogen and cleaved C3b. Here we show that PSPC is a pneumococcal plasminogen receptor, and that plasmin generated on the surface of the HUS pneumococci damages endothelial cells, causing endothelial retraction and exposure of the underlying matrix. From there, you can pick the red pill or the blue pill. End of quote. 2 more quotes and I'll have a gallon. But that's the pathophysiology of how pneumococcus causes hemolytic uremic syndrome. All you really need to do is know that such an article exists and Google it. I sure as hell won't remember the pathophysiology. And I still think that PNA is a stupid acronym for pneumonia. For you youngsters, that seems to be a relatively new abbreviation. We certainly didn't use it when I was an intern. And one last bit of good news, there's a meropenem-resistant strep pneumo spreading through Japan. Here's hoping it can't mate with that gonococcus we talked about earlier. That's an offspring I wouldn't want to deal with. And the superiority of beta-lactams In yet another study comparing outcomes of Staph aureus bacteremia, patients treated with glycopeptides had a higher mortality rate than people treated with nafcillin. If you learn one thing from listening to these podcasts, is that you should always treat MSSA with a beta-lactam. And you can skip the glycopeptide when treating empiric ventilator-associated or hospital-associated pneumonia if the nasal swab does not show MRSA. A negative nasal screen has a 96.5% negative predictive value and more. So remember, if you want to save some money and some toxicities and quit breeding resistance, if your patient has a nasal swab that does not show MRSA and you think they're developing pneumonia, you don't need to add MRSA coverage. There are so many things that mark me as old. I don't get tattoos. As an example, my children, I'm sure, could point out many other things that mark me as old. This week in clinic, I was seeing a patient in follow-up, and she's like 75. And for the first time, I said, well, people in our age group instead of people in your age group. Anyway, the more things change, the more things stay the same. Another article on sepsis and steroids. Should you do it? And the answer for this particular study is no. Patients in septic shock who were on a ventilator who received a continuous infusion of hydrocortisone had no better mortality than patients on placebo. You see, I was a medical student when the first sepsis and steroid study came out that showed benefit, and things have been going back and forth ever since. But then I think the only disease that's never been treated with steroids is Cushing's. And I'm probably wrong about that too. And something that does improve outcome in sepsis is prolonged infusion. The systematic review and meta-analysis, whatever that's worth, confirmed decreased mortality in patients who get prolonged infusions of piptazo. This review of 18 studies involving 3,400 patients showed that prolonged infusion was associated with a 1.46-fold lower odds of death. Constant infusion would seem to be the way to go with beta-lactams and sepsis. When do you do neuroimaging before a spinal tap? Well, two of the indications in the guidelines are altered mental status and immunocompromise. This study was interesting. They compared the outcomes of three different guidelines for neuroimaging: the IDSA, the European Society for Clinical and Microbiology and Infectious Disease Guidelines, and the Swedish guidelines. The Swedish guidelines don't include altered mental status and immunocompromise as reasons to do neuroimaging first. And they found that the prompt lumbar puncture that resulted in decreased mortality. And they suggest that an altered mental status or immunocompromised state should not be considered indications for neuroimaging before the lumbar puncture in patients with suspected bacterial meningitis. So the sooner you do the lumbar puncture and the more promptly you get antibiotics, the better the patient does. Chronobacter sakazaki is associated with neonatal infections. Usually it grows in infant formula. Baby drinks it, baby gets sick. There's a case report out of Australia of Chronobacter infection from contaminated expressed milk. And it's a reasonably ubiquitous organism, so put that on your list of milk-related infections. Wolfhartomonas. Seriously? Am I pronouncing that right? WHLFAHRTIIMONAS. That's Wolfhartomonas. That's almost better than the colonic strep Pasteurinus. Who says microbiologists don't have a sense of humor? Anyway, this organism is an occasional cause of bacteremia. The question is, what is the source? I would have thought with a name like that, teenage boys, but nope. It's insects, and specifically the green bottlefly. The case in question was a wet gangrenous foot with myiasis. And I've seen some flies in the occasional wound. Although whether the green bottlefly was the vector or the source, flies do carry bugs with them, is uncertain, given the small numbers of flies tested. But it seems pretty good considering that the guy had fly larvae in his wet gangrenous foot. They grew the bug out from his blood and from the fly larvae, and there are other case reports of myiasis leading to Wolfardia infections. Yeah, I know, you're only young once, but you can be immature your whole life. I'm going to giggle about this one for weeks to come. When I watch my colleagues do videos on things like Medscape, looking nice in their suits and seem so professional and adult, and I always think, that's not me. But more so, I feel sorry for the person of whom this was probably named after. I can't really find it on an internet search, but I assume somewhere there's a Dr. Wolfart. And I thought Crislip was a bad name. I recently had a patient from Africa in whom we accidentally diagnosed strongyloidiasis. He'd been having failure to thrive and couldn't eat and swallow, and his stool studies were negative, but a stomach biopsy showed Boku strongyloides. He's also an immunoincompetent patient. And one of the questions that came up was how long to treat. I actually went for a month on this patient, given the underlying immunoincompetency, and they got way better. Never did really prove disseminated strongyloides, but ... I was never really sure. A recent article on the treatment of strongyloides suggests that you don't really get rid of it. This study out of Argentina looked at outcomes in patients who got treated for their strongyloides, and they often found larvae by standard stool studies, but everybody had positive PCRs on the study up to a year after they got treated, suggesting that ivermectin, at least in the standard treatment regimens, is not efficacious in eliminating strongyloides. And so I feel a little better about treating this patient for disseminated strongyloides for a longer rather than shorter period of time. And really, it's all about making me feel good. It was my first case of strongyloides I have probably seen since I've been in practice, at least that I can remember. When I went back and reread all the literature on treatment regimens for strongyloides, suffice it to say it wasn't the most robust of clinical trials. It is sometimes best not to really know what goes into the medical literature. It's a lot like laws and sausages in that respect. And that brings us to an end of this Puscast, a review of the medical literature covering January 15 through 31 in the year 2018. References are available online at edgyduck.com, where you find links to my app, my other podcasts, my Medscape blog, and probably most importantly, my books. The Pus Whisperer 1 and 2, and Flies in the Ointment, a collection of my science-based medicine essays. That's 3 books, so you can have a library of Crislip material if you want. Otherwise, thank you as always for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I'm going to go watch The Sopranos. Talk to you later. Bye.